Good morning, ladies and gentlemen, esteemed jury, dear participants, listeners, ladies and gentlemen. Członkowie komisji, drodzy uczestnicy I słuchacze. On behalf of the Student Scientific Society of the Medical University of Silesia in Katowice, I would like to thank you for coming and taking part in the International Medical Congress of Silesia 2025. My name is Julia Ślążek, and I have the honor of coordinating the non-invasive cardiology session. We would also like to express our sincere gratitude to Club 30 of the Polish Cardiac Society for their esteemed patronage of this session. I would like to cordially welcome the esteemed jury, President of the jury, Professor Tomasz Kukulski, Professor Beata Średniawa, and soon Professor Andrzej Tomasik, who will join us later. We would like to explain the first rules of the session. The order of the presentation will be different as in the abstract book, but I will read everyone who will be starting. The maximum time for your presentation is 7 minutes and 3 minutes for discussion. And if the presenter exceeds the time, he or she needs to move on to the conclusions and finish the presentation as soon as possible. I would like to kindly remind you that if you are the supervisor on the paper which is presented, then you should not assess the work. So this is the comment to the jury. In that case, please cross out the number on the card. Other members of the same clinic are able to assess the presentation, and the assessment will then be verified. All the presentation and the discussion must be run in English. I would like to remind you as well that if the presentation is in English, then the discussion also should be run in English. And if the commission will ask the question in Polish, the authors still need to answer in English. And one comment to already at the end discuss what your contribution to the work was so that the discussion is shorter. We kindly ask the jury to assess the scientific value, the way of presenting, the discussion, and the own contribution of the authors on a scale of 1 to 5. When the session ends, we kindly ask you to give the cards back to the coordinator, and therefore we will begin. So to begin, I think we will start with the first presentation, which is: does the duration of atrial fibrillation and its clinical characteristic influence the ECV efficacy? Presented by Monika Bączek, and the other authors are Joanna Rak, Julia Gryl, Anna Barańska, Emilia Grabarczyk, and Franciszek Rej.
Good morning, ladies and gentlemen. My name is Monika Bączek, and I am honored to represent today the first department of cardiology in Katowice. I would like to present you our work titled, Does the duration of atrial fibrillation and its clinical characteristic influence the effectiveness of electrical cardioversion? I think it doesn't work. So let me begin my speech with a short theoretical introduction about atrial fibrillation, which is the most common arrhythmia in adults. It is estimated that up to 1 in 3 persons will experience this arrhythmia during their lifetime. On the ECG, it is presented as the lack of P waves and the irregular rhythm. Okay, the next. Based on the duration of atrial fibrillation, it can be divided into the 3 types. The first one is paroxysmal atrial fibrillation lasting less than 7 days. The second one is persistent atrial fibrillation with the duration time over 7 days. And the last one is long-standing persistent atrial fibrillation with the duration over 1 year. In most cases, atrial fibrillation have some symptoms, and the most common are palpitations, sweating, dizziness, and impaired exercise tolerance. We performed a study with the aim to assess the direct efficacy of electrical cardioversion in patients with persistent and long-standing persistent atrial fibrillation. We also want to evaluate the role of amiodarone in the preparation and its impact on the effectiveness of electrical cardioversion, both in these 2 subgroups. Moving to the materials and methods, we performed a single-center retrospective analysis, and after taking into the considerations of all inclusion and exclusion criteria, we qualified 355 patients to our study, and the study was conducted in years 2019 to 2024. Here you can see our inclusion and exclusion criteria. The most important was the duration of atrial fibrillation more than 7 days, and also we qualified only patients that underwent electrical cardioversion due to the atrial fibrillation. We take also into the consideration the possibility of collecting clinical data. We analyzed many parameters, such as demographic, for example, age, gender, or BMI. We also take into the considerations comorbidities and risk factors. Also, data about electrical cardioversion, such as used energy, return of sinus rhythm, or number of attempts were considered. And we also analyzed echocardiography parameters and results of laboratory tests. Our study group consisted of 355 patients. Most of them were male, and the mean age was almost 68 years. The general results revealed that the overall effectiveness of electrical cardioversion was 90.7%, and the mean time of duration of atrial fibrillation was 20 months. Amiodarone was used in the preparation in almost half of the patients. Our study group was divided into 2 subgroups. The first one consisted of 181 patients with persistent atrial fibrillation, and the second one, a smaller subgroup, was the subgroup of patients with long-standing atrial fibrillation, and it consists of 100 patients. We also analyzed the occurrence of symptoms in patients. As you can see, the gender, age, and BMI structure, both of this subgroup, was similar. Also, the occurrence of risk factors and comorbidities did not differ significantly in both of these 2 subgroups. Also, laboratory tests were similar in patients with persistent and long-standing persistent atrial fibrillation, which indicates the proper preparation for this procedure because all this electrical cardioversion were planned. What is worth to emphasizing, also the results of echocardiography involving left ventricular ejection fraction and the diminution of left and right atria weren't different in both of this subgroup. So it comes to there is no difference between the results in echocardiography with patients with persistent and long-standing persistent atrial fibrillation. As it comes to the effectiveness of electrical cardioversion, in both subgroups, the effectiveness were high and did not differ in a significant way. We also analyzed the energies used in the electrical cardioversion, and the structure was similar. The most common energy used in both of this subgroup was 150 joules, and more than 1 attempts were needed in almost 20% of patients. We also analyzed the ERA structure, and also it was similar in both of this subgroup with the most common class ERA 2. We also analyzed the effectiveness of cardioversion depends on the ERA class, and as you can see, in every class the effectiveness of electrical cardioversion was high and did not differ in a significant way. However, in ERA 4 classes, it may seem to be the highest percentage of ineffective electrical cardioversion. However, this group consisted only of 20 patients, so this is too small group to come into any conclusions. We also analyzed the use of amiodarone, which was used in almost 50% of patients with persistent and long-standing persistent atrial fibrillation in preparation. And after taking into the consideration the effectiveness depending on the use of amiodarone, it comes up that the usage of amiodarone did not improve the results of electrical cardioversion in our patients. So, in conclusion, electrical cardioversion should be attempted in all symptomatic patients with persistent or long-standing persistent atrial fibrillation. Direct effectiveness of electrical cardioversion in termination of atrial fibrillation is high, regardless of its duration and clinical characteristic. Amiodarone is often used in the preparation for electrical cardioversion of patients with persistent and long-standing persistent atrial fibrillation, but do not increase the effectiveness of this procedure. Ladies and gentlemen, this brings us to the end of our presentation. Thank you very much for your attention, and I will be pleased to answer any of your questions.
Thank you very much for excellent presentation. Very interesting study. At first, I would like to ask you about your contribution to this study.
So I and our colleagues come up with this idea of the study. Then we prepared the database, including all these parameters that I have told so far. Then we searched all the patients that underwent electrical cardioversion in the first department of cardiology in years 2019 to 2024. And then we qualified to our study only patients with persistent or long-standing persistent atrial fibrillation. We collected all data, then we calculate the statistic, prepare the abstract, analyze all the results of our study, and prepare this presentation with all charts.
Thank you. And my second question is, do you think that there are any different parameters which can influence the effectiveness of cardioversion? Because from this study you did not find anyone. So maybe you think that, for example, it was the first cardioversion, or maybe it was the next cardioversion, and what is about ablation in patients who underwent cardioversion, or do you?
Okay, so this was the first attempt of electrical cardioversion in all of our patients, and we think that there are not so easily to find these factors that influence the effectiveness of electrical cardioversion. We analyzed it all and we did not find any of them. It might be also caused due to the fact that the subgroup with ineffective electrical cardioversion consists of only 32 patients. So it is difficult to calculate a reliable statistic because the overall effectiveness of electrical cardioversion was almost 90.7%, which makes it a general very effective procedure. This electrical cardioversion, as I said, should be performed in any symptomatic patients with persistent and long-standing persistent atrial fibrillation. In the preparation also to the ablation, because we want to also to evaluate if these symptoms depends on the atrial fibrillation and if the condition of patients improves after this electrical cardioversion before the ablation, because these patients also have very common comorbidities such as heart failure or hypertension. So we want also to assess if the termination of arrhythmia improves the patient's condition. If yes, this patient should be then qualified to ablation in the further way.
Thank you very
much. Congratulations for elegant presentation. Short question, could you explain us what criterion for effectiveness of cardioversion did you apply for your analysis?
The criterion was the return of sinus rhythm after this procedure, and this sinus rhythm has to be continued during the whole hospitalization. Unfortunately, this is so big group that we did not have an access to the further medical history of these patients. So the criterion was returning of sinus rhythm during this procedure and then maintaining it up to the end of the hospitalization. And no further information about the recurrence of atrial fibrillation.
Regardless the duration of hospitalization, yeah?
Yeah.
Okay. Thank you.
Congratulations for the presentation. And now we would like to welcome the presentation, say AFib, When the Heart Skips, the Voice Slips, by Jonasz Osiecki, Miłosz Kasprzyk, Paweł Kurzelowski, and Monika Kalicka.
So, good morning, dear colleagues, dear professors. Can we actually hear an arrhythmia while talking to a patient? It turns out that this might be more feasible than it seems. My name is Jonasz Osiecki, and together with my close colleagues Monika, Miłosz, and Paweł from Student Research Group at the 3rd Department of Cardiology in Katowice, I have honor to present our current project, the voice analysis to predict the heart failure decompensation and rhythm disorders. Today I will show you the part of our study focused on atrial fibrillation. As you know, the AF is the most common arrhythmia in general population, from 1 to 2%, and over 10% in population over 80 years old. Also, AF carrying the life-threatening complications like stroke, pulmonary embolism, or systemic emboli. So our task, our task was to find a quick, non-invasive screening test. But we already have an ECG, you might say, and you would be right, but if story ended up here, I would not have several more slides to show you. So what if the ECG is paroxysmal, the AF is paroxysmal or self-limiting? What if it occurs when the ECG, even the simplest one, is not available? Or what if we can deliver a fast screening test that patient could perform themselves? So, this is contrary to appearances. This is not a frame from Stanley Kubrick film. This is a recording room at Digital Biomarkers Laboratory at the 3rd Department of Cardiology in Katowice, Katowice. We invited 20 heart failure patients, 10 with sinus rhythm and 10 with HF. And each one of them was asked to sustain a vowel just like that when we went to examine the throat. Yes, we know that the two groups of 10 are small, but this is that's a limitation of our study, driven by a logistic problem that AF has to appear during the recording. We also applied a propensity score matching to ensure that baseline characteristic did not bias our results. So the recorded samples are quality checked, all noise and background sounds are removed, the duration are normalized, and then we analyze the range of parameters. In a sense, we look at sound. Here you can see an oscillogram and spectrogram. In total, we extracted over 390 acoustic parameters and then grouped them into 3 categories. The first is prosodic variables. This is like intonation, stress, tempo, loudness and pitch. And these help human grasp and speaker's intent. Also, it's used in voice synthesis and even in Parkinson diagnosis. Then we have spectral features, less human, but they shape how we perceive timbre and also they describe the distribution of acoustic energy across frequencies. And the last one is voicic features. They describe how the vocal folds vibrate in terms like fundamental frequency, voicing duration, harmonics to noise ratio, voice onset time, and also jitter, its cycle-to-cycle period variation, and shimmer. This is a cycle-to-cycle amplitude variation. So, among all the parameters, the best discrimination was jitter DDP. Both its mean and median differed significantly between the AF group and the group with sinus rhythm, and we tested by the human Whitney test. We do not show here any absolute values of the jitter DDP because it's not yet a medical marker. So we focus on qualitative analysis to avoid over-interpreting numbers. Our goal was only to find whether the marker is potentially useful. So what are the jitter and the jitter DDP? The jitter quantifies the variability in duration between phonatory cycle. A phonatory cycle is from closure to closure of our voice folds. And cycle length is it depends of fundamental frequency, and the jitter DDP is an average of differences between those period differences and making it more sensitive to irregular fluctuations. So why might AF alter this? The literature here is scarce, but we have two plausible mechanisms. The first is laryngeal edema, and the second one is autonomic influence of the arrhythmia. So, among the voice parameters can be very promising in AF detection. We have here that the jitter DDP standing out as a markedly higher in the AF group than a sinus rhythm group, and voice analysis could become a promising non-invasive tool for AF detection, but as with any pilot study, we need a larger cohort to confirm this clinical utility. So at the end, I want to, on behalf of the entire student team, thank our mentors, Professor Wojciech Wojkowski, Professor Tomasz Jadczyk, and Dr. Engineer Daria Hemmerling for giving us this opportunity and trust and take part in this project. Thank you so much for your attention, and I invite you to discussion.
Thank you for the presentation. This is, of course, a very attractive concept to combine vocal tone with atrial fibrillation. The first question, of course, is what was your
contribution
in this work?
Of course. First, we, of course, take a part of this study with a patient, so we prepare all documents. After that, by an electric stethoscope, we collect the data from our patient heart and also lungs. After that, we record all of the samples in this recording room that I showed. Can I take this one? Okay, it's off. So we take the patient to the recording room and do all the exercise, because as I said, this is the part of our study. The sustaining a vowel A is one of them. We have 6 exercises, and we do it 6 voice exercises, and we do it with a patient. And after that, also we collect all of this recordings, and in the first part we try to also manage these recordings to get a quality checked and a little bit noise and background sound removed. So this is our all of our team contribution to this study.
My question is about the meaning of your results. What do you think this method is promising, and it is rather for screening for AF, or do you think it will be useful in clinical practice? What do you think?
For now, of course, it's not. But the results of this part and the other parts are promising. But the main reason to implement this step have to be enlarged cohorts, because, for example, we use it a propensity score matching because of that small group, and, for example, in this formula of propensity score, we could not add some very reasons that could affect to our vocal folds and change this jitter. So if we have a large enough cohort, I think it could be very promising to AF and the other heart diseases detections.
But rather for screening, not for diagnosis.
Yeah, only for screening, of course.
I think that the major work is done by the phoniatric. Yeah, that is phoniatric work.
Yes.
To analyze the spectrum of this acoustic spectrum. So you need close cooperation, even not even with laryngologists, but with the phoniatry department. Yeah.
Here with this work, we have a cooperation with Akademia Górniczo-Hutnicza w Krakowie, and this also with not exactly the phoniatric department, but a machine learning department, because they try in AGH w Krakowie to make a machine learning model. So it's the most cooperation is with AGH w Krakowie.
Okay, thank you very much.
Thank you so much.
Thank you very much for the presentation. Now I would like to welcome the next presenter with the work titled Contrast-Associated Kidney Injury in Patients with Glucose Abnormalities Treated Invasively Due to AMI by Katarzyna Lis, Gabriela Mysłek, and Monika Otocka. Thank you.
Good morning, everyone. My name is Katarzyna Lis, and today I'm honored to present to you our study about the risk of a contrast-associated acute kidney injury and its prognostic significance in patients with glucose abnormalities who were treated invasively in acute phase of myocardial infarction. Patients with acute myocardial infarction are subject with a high mortality risk, especially those with many comorbidities. We focus on a subgroup with a renal dysfunction accompanying with a glucometabolic abnormalities. May I please turn my slides, because this is not working? Hello, please. Oh, thank you. So the aim of our study was to determine the prevalence of CAA-KI and its significance prognostic in the subgroups of patients with glucometabolic disorders who were treated invasively for acute phase of myocardial infarction. Our study consists of almost 4,600 patients who were treated for AMI with PCI. All patients were provided with treatment in the Department of Cardiology and Electrotherapy in a Silesian Center of Heart Disease in Zabrze. To diagnose glucometabolic abnormalities, we use a history of DM, the results of in-hospital fasting glycemia, and the oral glucose tolerance test. On this basis, we identify several subgroups with glucometabolic disorders and analyze it with respect to CAA-KI definition, which is written below. Mean follow-up was 3 years. Among the whole study population, 644 patients developed CAA-KI. It means almost 13%. The most common disorders were newly diagnosed diabetes, almost 20%, and previously diagnosed diabetes, almost 18%. The next common disorders were impaired glucose tolerance and impaired fasting glycemia. Also, our control group, as a normoglycemic patients, developed CAA-KI. It means 11.2%. Patients with impaired glucose tolerance, new DM and previous DM had a more frequently prevalence of CAA-KI compared to normoglycemic patients. Exclusively, patients with impaired fasting glucose level had a lower prevalence of CAA-KI compared to normoglycemic group. However, it was not significant differences. Patients with showed significant differences in the clinical characteristic, such as age, hypertension, hyperlipidemia, hematocrit level on admission, cardiogenic shock, and also renal and cardiac function. The most relevant in our view are presented on this table. As shown in the Kaplan-Meier estimator figure, the presence of CAA-KI were related with a worse prognosis in almost every study subgroups except the impaired fasting glycemia one. Among this group, the annual mortality rate was not significantly higher between patients with CAA-KI and those without acute kidney injury. This slide shows a comparison of survival across several glucometabolic cohorts. In each of them, we combined patients with impaired glucometabolic disorders and CAA-KI and those without acute kidney injury. An additional analysis were conducted for a combined diabetes cohort. As we can see, the presence of CAA-KI were related with a worse prognosis in almost every study subgroups except the impaired fasting glycemia one. The most pronounced differences were observed in a previous diabetes cohort where the survival curve diverged rapidly. All parameters that showed significant differences and were related with higher mortality rates or could potentially influence the mortality risk were involved in multivariate Cox regression models, and the evaluation of this test came with results that the age was a sole factor consistently associated with higher mortality rates in all study subgroups. The patients with the presence of CAA-KI were identified as independent predictors of all-cause death in almost every study subgroup except the impaired fasting glycemia one. And however, ejection fraction below 35% at discharge were independent predictors of death in almost every study subgroup except the newly diagnosed diabetes cohort. Analyzed the aforementioned results came with a conclusion that glucometabolic states, the risk of renal complications, and long-term prognosis in patients with glucometabolic disorders who were treated with for AMI have significant differences. Patients with acute renal failure, like a CAA-KI is a common complication with patients with glucometabolic disorders. Also, patients with glucometabolic disorders such as impaired glucose tolerance, new DM and previous DM. Also, patients with normoglycemia who developed CAA-KI determinate the significantly worse prognosis. Patients with impaired glucose tolerance had a lower percentage of CAA-KI and a better prognosis in patients with normoglycemia. That's all for us. Thank you for your attention.
Thank you. And now we will begin the 3-minute discussion. First, I would like to ask for your contribution to the work.
Okay, so my contribution to the work is actually analyzing the data which was collected by our works tutor, because the data is from 2004 and 2014, when our Department of Cardiology and Electrotherapy has a procedure to collect the OGTT levels during admitting patients to the hospital. And with my colleagues, we try to analyze this problem, which is CAAKI in patients after myocardial infarction while treated invasively for this disorder. And we collect the important knowledge to compare our work to study that is already have been done, but we have some problems because our work is, in my knowledge at this day, the first one that came with an idea to verify differences in 5 glucometabolic subgroups and this impact in CAAKI.
The endpoint you used for the analysis was total mortality or cardiovascular mortality, or also the hospitalization due to?
We use total mortality, but patients who died during hospitalization were out of this study.
How did you assess the endpoint? Did you have access to the registry of these patients?
Yes, as I said, our work tutor collected this data during further analysis. When we came to this when we came up to the study group, that our work tutor came with the idea to use this database. So we agreed to this because we think that it's important to highlight the problem of patients with glucometabolic disorders, because the myocardial infarction is a common disorder in these days, and we think that it's important to know the differences in patients.
Good morning. First, I would like to apologize you for being late today, and I'm impressed with the work you have put into this presentation, and for very brilliant presentation of the material you have presented. Congratulations. I will hold the grading of the abstract and the presentation because I'm late, but I congratulate.
Thank you very much.
Thank you for your presentation. Thank you for your presentation. Welcome, Professor Tomasik, to the jury. And now we will continue with the 4th presentation, which is the relation between selected echocardiography parameters and comorbidities in severe aortic stenosis by Tomasz Lemek, Adam Priatka, and Jakub Garbacz, who may not be here.
I am here. Hello.
Okay, so they are online. So if you can hear me, then if you are ready, you can start the presentation. You should be able to move your own slides.
I could share my own screen and move the slides. I don't know how to move them here. Can I? Yes, I'll try to do that. Can you see it? Can you see the presentation?
We can't hear you, unfortunately.
Oh. Can you hear me?
Yes, now we can hear you. So if you can start, then.
All right, great. You can see the presentation, right?
Yes, we can see the presentation, and you have 7 minutes.
All right, great. So I'll start. Good morning to everyone. My name is Tomasz Lemek. I'm a fourth-year medical student at the Jagiellonian Medical University in Krakow. And I would like to present our study about the relation between selected echocardiographic parameters and comorbidities in severe aortic stenosis. Aortic stenosis is the most prevalent valvular heart disease in developed countries, with increasing incidence due to population aging, affecting approximately 4% of individuals over 75 years of age. Comorbidities in these patients significantly influence both the urgency and selection of treatment modalities. When certain comorbidities affect cardiac hemodynamics independently of the stenosis, the severity of the valvular defect may be misclassified during a cardiographic assessment, which potentially can impact clinical decision-making. So this study aims to determine how selected echocardiographic parameters differ based on the presence of common cardiovascular comorbidities in patients with severe, mainly severe aortic stenosis. We retrospectively analyzed data from 126 patients. This is post-exclusion, obtained from electronic clinical records between 2019 and 2024 in 2 adjacent cardiology units. All patients underwent echocardiographic assessment within 1 month of admission. The measured parameters included aortic valve area, mean and maximal aortic valve pressure gradients, maximal aortic valve velocity, left ventricular ejection fraction, stroke volume, left atrial area, and the E/E' ratio. Each patient was screened for the presence of prior PCI or CABG interventions, myocardial infarction, systemic hypertension, type 2 diabetes, dyslipidemia, atrial fibrillation, and kidney and thyroid disease. The exclusion criteria were previous valvular procedures, congenital heart defects, and non-degenerative valve defects, with the sole exception of bicuspid aortic valve. And pre-admission medications were also documented. In this table, let me get the pointer. In this table, you can see the physiological ranges of the echo parameters I previously listed. The most important parameters routinely used in the evaluation of the severity of aortic stenosis are aortic valve area, maximal velocity, and the mean gradient. If either one of these criteria are met, so AVA below 1 centimeter squared, Vmax above 4 meters per second, or mean gradient above 40, the defect is classified as severe. You might recall that a measurement of the maximal gradient was also performed, but maximal velocity is obtained in practically the same way through continuous wave Doppler, and one can be calculated from the other, so including either one is enough. The left atrium area is also an important measurement because it's a reflection of the chronic pressure overload in the left ventricle caused by the stenotic valve. The left ventricle is overloaded with pressure, it backs up into the left atrium, and it enlarges it over time. An enlarged left atrium is also linked to a higher possibility of diastolic dysfunction, which brings us to the E/E' ratio. The significance of it is that it provides a good estimate of left ventricular filling pressures, which helps assess the degree of diastolic dysfunction. The bigger this ratio, the worse the dysfunction. The patient's median age was 75 years, with females comprising 50% of the population. As shown on the graph, the most frequent comorbidities were hypertension, dyslipidemia, and atrial fibrillation, followed closely by type 2 diabetes. 74% of the patients were using beta blockers, 57% ACE inhibitors, 62% on diuretics, and 26% on calcium channel blockers. After statistical analysis, we got the following results, as shown on these box plots. The mean gradient was lower, so closer to the physiological range in patients with atrial fibrillation, prior PCI or CABG interventions, and hypertension. Similarly, in all 3 of those same group comparisons, the maximal velocity was lower in patients burdened with those comorbidities, which seemingly suggests a less severe valvular defect. An important point to note is that low flow, low gradient states have been previously studied and linked to worse outcomes following transcatheter aortic valve implantation when compared to high gradient severe aortic stenosis. Left atrial enlargement was more advanced in patients with atrial fibrillation, hypertension, and type 2 diabetes. Atrial fibrillation and hypertension most likely by contributing to volume and pressure overload, whereas diabetes not only causes myocardial fibrosis and as a consequence diastolic dysfunction, but also possibly through a link to coronary microvascular dysfunction, which can contribute to the remodeling of the atrium. In conclusion, the fundamental echocardiographic parameters routinely used in AS assessment vary significantly with the presence of cardiovascular comorbidities. In concomitant atrial fibrillation and systemic hypertension, lower mean gradient and maximal velocity values should be expected. Atrial fibrillation, hypertension, and diabetes mellitus seem to affect left atrial remodeling, potentially through an association with diastolic dysfunction and an independent atrial cardiomyopathy. The findings shown in our study showed the importance of optimal management of comorbid diseases in patients whose hemodynamic function is already being impaired by aortic stenosis. The references, and this concludes my presentation. Thank you very much for the attention. And as requested, my contribution to the work was study design, data gathering, and statistical analysis. So I contributed at every step. Thank you.
Thank you for your presentation. And now to questions to the jury.
Congratulations for a very nice presentation. And I have a methodological question. How do you think, can you infer the causal effect between the comorbidities and the severity of aortic stenosis?
The comorbidities can confound the evaluation of the severity of the aortic stenotic defect. So, for example, let's say a patient with atrial fibrillation comes to the echocardiographic assessment and they are not in normal sinus rhythm. So we can judge that, for example, this was a pilot study, so we didn't do this in this study, but in echocardiography, we can, for example, look at the presence or the lack of the A waves and tell if the patient is, or the EKG, and tell that the patient is during atrial fibrillation. So the hemodynamic flow is altered, and this can potentially lead to misjudging of the defect. But every comorbidity has its own explanation for how it confounds the judgment.
But I mean, the cross-sectional study design has the least power to infer any causal effect between studied parameters and the eventual progression of the. Of course, the comorbidities you have studied, we have to take into account considering any treatment options for the patient. But I mean, it would be more interesting for physicians if you could answer or find the answer how the comorbidities, I mean diabetes, I mean chronic kidney disease, infer the progression of aortic stenosis.
Yes, of course. Okay. This was a retrospective study, not prospective, and it has its limitations.
Thank you.
I would like to ask you about your contribution to this work and what is new in your results and new conclusions.
I contributed to the work by working together with my colleagues on the study design, creating the base of the patients. I also gathered data together with them and conducted statistical analysis with my colleagues. What's new in the study is, well, in this pilot study, there isn't really a work out there that takes all of those comorbidities together and analyzes them in this specific constellation. But afterwards, after this pilot study, we expanded a little bit on the idea, and like I mentioned before, we looked at atrial fibrillation by judging by the A waves on the echocardiographic assessment, and it has not been done before with this particular methodology.
And unfortunately, we have run out of the discussion time. So if you agree, Professor Kukulski, then we will continue with the next presentation. And the next presentation is Automatic Assessment of Coronary Artery Stenosis from Coronary CTA versus Reference Invasive Coronary Angiography by Julia Dudek and Olivia Barnaś.
Good morning, ladies and gentlemen. My name is Julia Dudek, and with my colleague Olivia Barnaś, we prepared presentation comparing automatic coronary stenosis assessment using CTA with the reference standard invasive coronary angiography. For the introduction, ischemic heart disease is the leading cause of death in Poland and other developed countries. About 2.5% of Poles suffer from chronic IHD. Two main imaging methods are used. The first one is ICA, invasive coronary angiography, which is invasive but still remains a gold standard, and CTA, which is non-invasive but usually interpreted visually, which is subjective. Our study evaluated an AI-based automated CTA approach. Thank you. Before diving into the results, I would like to show you this slide, which shows plaque analysis using AutoPlaque 3.0, the software developed in Cedars-Sinai Medical Center in Los Angeles. This is the CCTA-based tool for semi-automated quantification of coronary atherosclerosis. The panel displays segmentation of non-calcified plaque, which is the red color on this slide, along with anatomical reference, which you can see on your right side. The software enables detailed assessment of plaque burden and morphology. Our goal was assess whether automated CTA stenosis measurements align with ICA. We retrospectively analyzed 61 plaques from 50 patients who underwent both ICA and CTA at our department. CTA was processed with AutoPlaque 3.0, aiming to eliminate subjectivity. In both CTA and ICA, stenosis was calculated as percentage of plaque volume to vessel volume. AutoPlaque automatically categorized plaques by type to calcified, non-calcified, and lipid-rich. Calcified was interpreted as greater than 350 Hounsfield units, non-calcified as less than or equal 350 Hounsfield units, and lipid-rich as less than or equal 30 house wind units. Also, stenosis were grouped into 6 severity levels from 0% to greater than 90% to standardized comparison between CTA and ICA. In moderate stenosis cases, median values from CTA and ICA were similar. No significant difference and linear trend suggests that CTA can reflect ICA results well. Agreement in assigning to group between these two methods was moderate, with Cohen's kappa 0.428. The results suggest that automatic CTA classification generally aligned with ICA, though some discrepancies were found. Stenosis was misclassified in 41% of cases, with overestimation in 26% and underestimation in 15%. Importantly, 75% of overestimations occurred in heavily calcified plaques. This plot shows that most overestimations, which are dots above the zero line, happen with near total calcification. This pattern suggests that heavy calcification may impair the accuracy of automated CTA, particularly leading to overestimation of stenosis severity, possibly due to blooming artifacts in CT imaging. In summary, automated CTA assessment is comparable to ICA. However, limitations exist, especially in calcified plaques, and clinical judgment should still be applied. Automatic CCTA assessment offers reliable, fully non-invasive alternative for coronary artery stenosis evaluation. It can reduce the need for procedures, improve diagnostic workflow, and provide standardized measurements. Thank you for your attention, and I'd be happy to answer any question.
Thank you. So first I will ask the question that the jury asks always. So what was your contribution to the work?
Okay, so first we discussed our topic with our supervisor, Dr. Magdalena Dobrolińska. Then we participated in data collection, in CT images selection, and we collected data about ICA from patients' medical records. Then we learned how to use AutoPlaque 3.0. We performed the automatic analysis using this software. Then we contributed to statistical analysis. We wrote the abstract and prepared this presentation.
I have a practical question. Also, this is automatic analysis. It takes some time. Did you perform this analysis by your own? And how much time it took for you?
It took about 10 minutes to do from first step to the results.
Okay, thank you.
If may I ask you a question? I will ask you from a practicing physician point of view. If you have a medium-aged man with a high coronary artery disease probability, smoking, hypertensive, with diabetes, and typical exertional dyspnea, and you have non-significant stenosis assessed with automatic tomography analysis, will you postpone the invasive coronary angiography?
For now, no, but I think that this tool is very promising for the future. We have to train it because this is AI-based tool. So I think that in future it could be possible.
Could the patient have saved the radiation, contrast dose, and the time waiting for CT analysis, assessment, and then angiography? Think of this. Think of pretest coronary artery disease probability. Thank you.
Thank you.
Thank you for your presentation. Thank you for the questions. And now I would like to welcome the presentation titled Do SGLT2 Inhibitors Impact on Efficacy of Pulmonary Vein Isolation and Clinical Course of Patients with Heart Failure with Preserved Ejection Fraction and Atrial Fibrillation? Prepared by Karina Dzięcioł, Adriana Filak, Anna Hejmej, Aleksandra Spirkowicz, Mikołaj Goda, and Piotr Paździora.
Good morning, ladies and gentlemen, honorable jury and esteemed guests. Thank you for the opportunity to present our work today. Together with my colleagues, we were honored to conduct a study on the impact of SGLT2 inhibitors on efficacy of pulmonary vein isolation and the clinical case of patients with heart failure with preserved ejection fraction and atrial fibrillation. To begin, I'd like to briefly introduce key points that form the foundation of our study. SGLT2 inhibitors are a relatively new class of drugs that was initially developed as anti-diabetic agents. But, however, nowadays they've shown some beneficial cardiovascular benefits, especially in patients with heart failure. PVI, or pulmonary vein isolation, is a catheter-based procedure that electrically isolates the pulmonary veins in order to prevent ectopic triggers for atrial fibrillation. Heart failure with preserved ejection fraction and atrial fibrillation are often coexisting conditions, each worsening the clinical case of the other. Exploring whether the SGLT2 inhibitors impact the efficacy of PVI procedure in these patients is clinically relevant. In this slide, I'd like to shortly introduce key effects of SGLT2 inhibitors in patients with HFpEF and AF, and these include reduction of left atrial pressure, anti-inflammatory and anti-fibrotic effects, improvement in myocardial energetics, and reduction in epicardial fat volume. Now I'd like to shortly explain what does it mean for us. A reduction of left atrial pressure may alleviate the symptoms of congestion and atrial decrease. Anti-inflammatory and anti-fibrotic effects may limit structural remodeling of atria and myocardium. Improvement in myocardial energetics, mainly thanks to the shift towards ketone metabolism, is more oxygen efficient. And reduction in epicardial fat volume is relevant not only because epicardial fat is a marker of metabolic risk, but may also cause local inflammation that may lead to arrhythmogenesis. The aim of our study was to assess the impact of SGLT2 inhibitors on efficacy of pulmonary vein isolation and the clinical case of patients with heart failure with preserved ejection fraction and atrial fibrillation. There was a retrospective analysis that was conducted at the first department of cardiology in the Upper Silesian Medical Center in Katowice. Our study group consisted of 48 patients that were diagnosed both with atrial fibrillation and HFpEF, and we divided them into two groups, those who were treated with SGLT2 inhibitors and those who were not. During our study, we took into consideration specific inclusion and exclusion criteria. Our study group consisted of patients who were diagnosed both with AF and HFpEF, who underwent catheter ablation therapy, and who were treated with SGLT2 inhibitors. While from the study, we excluded patients who experience AF recurrence after PVI procedure who were not treated with SGLT2 inhibitors or who presented left ventricle ejection fraction below 50%. Out of our 48 patients, 23 of them were women and 25 of them were men. The median age of our patient was 63.5 years and the median BMI was 31.2. In our study group, we took into consideration the classification of patients according to the EHRA and NIHA scale. In our study group, most of the patients, according to the EHRA scale, were classified as class 2B, in comparison to NIHA scale, where the majority of our patients were classified as class 1. In our study, we also took into account concomitant diseases that were presented in our patients. The majority of our patients were presented with arterial hypertension. That was 89.6% of our patients. Hyperlipidemia, 70.2% of our patients. Atrial fibrillation paroxysmal type, that was presented in 30 patients. And diabetes, that was presented in 43.8% of our patients. During our study, we analyzed imaging studies such as ECG, Holter monitoring, echocardiography, specific laboratory parameters, specific quantitative and qualitative variables at the baseline, and finally outcomes after the PVI. Study period was from 2013 to 2024. We retrieved clinical data from electronic medical records and also from phone calls with our patients. Here I'd like to tell about the results. This table shows us the baseline, the quantitative variables at the baseline. As we can see, study group consisted of patients who were slightly older than those in control group, with the mean age of 66.3 years in the study group and 60.7 years in control group. And also the CHATS VA scale was higher in our study group. Other parameters such as BMI, left ventricle ejection fraction, left atrium area, LWT, creatinine and LDL levels showed no p-value associated significant difference, and this allowed us to assess for an accurate assessment of the impact of SGLT2 inhibitors on the efficacy of PVI procedure. The second table shows us qualitative data about our patients. As we can see, there was no significant difference in the type of atrial fibrillation, history of hyperlipidemia, or coronary artery disease. This table shows us the results of PVI in 1 year follow-up. As we can see, the mortality within 1 year was higher in our control group. And what is important to outpoint is the symptom improvement that was presented in our study group. When it comes to limitations of our study, we have to tell that we only analyzed 48 patients, so this was a small population of a study. This is because of the fact that we could analyze patients who were treated with SGLT2 inhibitors.
The time has finished, so if you may please continue to the conclusions.
Okay. Sorry, the pointer is not working. In conclusion, we'd like to say that SGLT2 inhibitors treatment does not seem to increase PVI efficacy. However, it shows us that it may lead to symptom reduction and better prognosis in those patients. Thank you for your attention, and I'd be honored to answer any of your questions.
So maybe first question about your contribution and novelty of this work.
My contribution to this work was doing some research on similar topics in other publications, and After that, we had to prepare proper database, where we have to choose proper variables that we would like to analyze. Later, we had to collect data from electronic medical records and also from phone calls with our patients. My contribution was also, together with the help of our works tutor, preparing the statistics.
The next question is about how did you assess the efficacy of vein isolation? And the second question is about method which were used to vein isolation, because nowadays there are at least 3 methods. What method was used in this group?
So we analyzed the efficacy of PVI isolation by analyzing cardiac evaluations such as ECG, echocardiography, and Holter monitoring. We also, because of our phone calls with patients, we asked them if they experienced any kind of MACE events within 1 year follow-up after the procedure.
How often did you make Holter monitoring or ECG in this 1 year to assess efficacy?
Sorry, I cannot answer this question.
Okay. Maybe something about the methods, do you know? Because it is pretty, how to say, old material between 2013 until now. So different methods were used in this period. Do you know any method which was used?
Sorry.
Okay.
Congratulations, very interesting topic. And I have only my methodological comment. You have analyzed the reports, patient reports between 2013-2022, and there was substantial recommendation progress for use of SGLT2 inhibitors in overall cardiology. And you have very small number of patients, just 48, yes, and divided into 2 groups and studied and control. And if you start systematically to, or even in blinded or open label administer SGLT2 inhibitors, you will, I think, you will receive reliable results indicating that that's the future method to reduce the atrial fibrillation relapse in this patient. Congratulations.
Yes, thank you for your remark, and we surely take it into consideration in our further studies because we want to broaden our patients' data for more patients. Because we know, I'd like to tell that given these results, because of the small population group, we have to take into consideration that we should take these results with, we should interpret these results with caution, and of course, further studies are warranted.
Thank you for your presentation. Thank you for the discussion. And now we continue with the 7th presentation today, which is clinical implications of atrial fibrillation in patients with HCM, heart failure symptoms, and SCD risk evaluation by Piotr Koźmiński, Dominika Denisz, Maciej Gretka, Julia Korcz, Natalia Koza, and Karolina Król.
Good morning, ladies and gentlemen, dear jury. My name is Piotr Koźmiński, and I represent First Department of Cardiology of Medical University of Silesia in Katowice, and I would like to present our work entitled Clinical Implications of Atrial Fibrillations in Patients with Hypertrophic Cardiomyopathy, Heart Failure Symptoms, and SCD Risk Evaluation. To give a brief background, hypertrophic cardiomyopathy is a condition that is diagnosed by discovering thickening of left ventricular wall equal or above 15 millimeters with no visible cause, and also excluding other possible causes of this concentric hypertrophic remodeling of left ventricle, such as aortic stenosis or hypertension. It often also has some genetic background. I'm specifically talking about sarcomere-related proteins and sarcomere genes. The symptoms may vary from those resembling chest pains to syncope episodes, or even ventricular arrhythmias such as ventricular tachycardia, sustained or non-sustained. And two key factors that should be considered when talking about the course of HCM are heart failure symptoms and hypertrophic cardiomyopathy risk of sudden cardiac death score, which is calculated via the formula listed below. Those two main goals of monitoring the course of the disease those patients often also have atrial fibrillation, which comes with its own possibly fatal consequences, such as thromboembolic episodes, and can impact further left ventricular function degradation. So me and my team have raised the question, does atrial fibrillation in those patients become stronger risk factor for heart failure symptoms, the more prevalent left ventricular ejection fraction reduction, or sudden cardiac death? In order to answer it, we have analyzed 97 patients, all hospitalized between years 2020 and 2025 in Górnośląskie Centrum Medyczne imienia profesora Leszka Gieca in Katowice, which we have divided into two subgroups, one with atrial fibrillation consisting of 37 patients, and the second without atrial fibrillations, 60 patients. The clinical parameters that have been analyzed were the NIHA functional class of heart failure symptoms, with assigning the patients into 4 groups according to those classes, as well as general prevalence of symptoms. Also left ventricular ejection fraction and its significant reduction, that for patients with HCM is below 50%, in contrary to general population, which is 40%. And their HCM risk SCD score based on European Society of Cardiology criteria from 2023 for ICD implantation. The first result of our study has shown that atrial fibrillation had no impact on HCM risk SCD score in both subpopulations. 23 patients without dysarrhythmia had risk score above 4%, and 15 of those with arrhythmia, that is respectively 38.3% and 40.5%. And here's the graphical presentation of those numbers. When it comes to their distribution across Neurocard Association class of heart failure symptoms, we can see that the distribution was similar. However, it is important to note that only singular patients have represented the most severe symptoms classified as class 4, which is a good point to consider further analysis on a much larger population. It is generally a much better view of this topic on the graph. The general symptomatic symptoms of heart failure also were not different in two groups, despite the different percentages. 59.5% of patients with atrial fibrillations had symptoms, and 46% without atrial fibrillation. The most interesting results, however, were shown by analyzing the left ventricular ejection fraction, as I have said before, reduced below 50%. patients with atrial fibrillation were in much greater numbers showing reduction of the ejection fraction than patients without it. 21.6% in contrary to 6.7%. The correlation was shown in a borderline kind of manner, but when we should we expand this analysis into some more numerous population, it would surely become and is clinically important for assessing their quality of life due to appearing of symptoms, potential appearing of symptoms. And here are the direct numbers and percentages. To conclude our work, atrial fibrillation and the hemodynamic effects that it has, such as ineffective atrial contraction and desynchronized ventricle depolarization, which impair the passive influx, which is of great matter for patients whose ventricle is initially has initially impaired contractility, has an important influence on more frequent left ventricular ejection fraction reduction in those patients. However, no correlation of atrial fibrillation with aggravation of their heart failure symptoms was shown as of now. However, it is important from a clinical point of view to note that when we screen those patients for left ventricular ejection fraction reduction early and implement the treatment early, we give them much bigger chance of enjoying debilitating symptoms-free life. And also, I would like to mention that in the view of 2023 criteria for ICD implantation in primary prevention made by European Society of Cardiology, New York Heart Association class of symptoms above 2, or in general symptoms of heart failure, are an independent risk that enables patients with SCD risk score below 4% to be considered for ICD implantation in primary prevention. And to conclude our analysis, atrial fibrillation has no impact on HCM risk STD score nor HF symptoms in those patients. However, patients with atrial fibrillation have displayed much higher left ventricular ejection fraction reduction prevalence. Hence, it's important to further monitor them in case the symptoms appear in the future. And further analysis on a larger study cohort that we plan on doing in the future might help us assess our current discoveries and maybe discover more correlations regarding this topic. Thank you for your attention.
Thank you for your presentation. So first, I think the jury probably would like to ask for your contribution to the work.
So our contribution to the work was gathering all the clinical data that I have mentioned before, which included the class of symptoms based on the medical history of patients, all during their most recent hospitalization. And also their ejection fraction from most recent echocardiography conducted in the first department of cardiology. However, we did not take their HCM risk SCD scores from the medical history. We have calculated them ourselves based on the most recent symptoms and also the most recent discoveries in echocardiography. And we have assessed them into three subgroups regarding the risk: below 4%, 4 to 6%, and above 6%. This they may not, in the view of the most recent criteria, be this much different in case of implantation, but we have also studied the medical history from 2020, when the previous recommendations were obliged us to much different approach to the situation. And we have analyzed this parameter statistically and prepared this presentation for you.
I have some comments to this work. I think that the parts of your work related to the impact of AF on clinical course is not very new. We know very well what's going on with the patients hypertrophic cardiomyopathy once the ejection fraction atrial fibrillation will start, since the atrial fibrillation is a simply consequence of a diastolic dysfunction, which is during the life course, the main mechanism of atrial enlargement and finally development of atrial fibrillation. So I think the part of your work which is focused on the possible relation with sudden cardiac death is interesting. Which of the criteria did you use, the ESC score or the ACC score?
The ESC criteria, which have been updated in 2023, that all groups, depending on presence of other clinical symptoms, which are the reduction of ejection fraction below 50%, which was the most prominent to our study, and the second one is a late gadolinium enhancement above 15% of the volume of the heart in cardiac MR. If these two are present, we can consider also the group below 4%.
And unfortunately, we have run out of time for the discussion, so if I may excuse myself,
okay,
and thank you for your presentation. And now we invite the next presentation, which is morphological analysis of coronary plaques in patients with aortic stenosis versus matched controls by Olivia Barnaś and Weronika Nowicka.
Good morning, my name is Olivia Barnaś, and together with Weronika Nowicka, we conducted a study at the Department of Cardiology and Structural Heart Diseases in Katowice under the supervision of Dr. Magdalena Dobrolińska. And today I am honored to present to you our research titled Morphological Analysis of Coronary Plaques in Patients with Aortic Stenosis versus Matched Controls. Let's begin with a very brief definition of aortic stenosis, which is a narrowing of the aortic valve opening, which restricts blood flow from the left ventricle to the aorta during systole. It is often associated with atherosclerosis of coronary arteries, which is a chronic progressive disease characterized by accumulation of plaques within arterial walls, leading to the impair of blood flow to the myocardium, which may potentially result in ischemic heart conditions such as angina pectoris and myocardial infarction. These both conditions have many features in common, such as shared risk factors. For example, hypertension, hyperlipidemia, smoking, and aging. They may also have a pathophysiological link, as they are both degenerative diseases associated with chronic inflammation and calcification, which led us to ask a very important question. Is there any significant differences in coronary plaques in patients with aortic stenosis and those without? So in our study, we enrolled 60 patients and divided them evenly into two groups. The patients with aortic stenosis, which included 14 females and 16 males in the age of 65 to 93 years old, and the patients who did not present this heart valve condition, which was 16 females and 14 males in the age of 50 to 86 years old. The selection of patients was based on their CT scans image quality and visually evident atherosclerosis. The plaques were classified as calcified plaques if their attenuation was greater than 350 Hounsfield units, and plaques that were non-calcified were classified if their attenuation was lower or equal to 350 Hounsfield units, And if attenuation was lower or equal to 30 Hounsfield units, we classified them as lipid-rich plaques. The morphology was analyzed using Autoplaque 3.0 software, which is a semi-automatic tool. Here's an example of coronary artery analysis using this software. As you can see, the software analyzes coronary arteries based on criteria I mentioned before. It summarizes them in the adjacent table, for example, vessel volume, plaque length, etc. Moving on to the results. As you can see, our study shows a great difference in calcified plaque composition within our study groups. For the patients with aortic stenosis, the calcified plaque composition median was equal around 100, and for those without, 25.6. To better understand these differences, we visualized our data as follows. As you can see on this box plot graph, the higher calcified plaque composition for patients with aortic stenosis is not the only difference. You can see that in the group with patients without these heart valve conditions, the range is broader, which indicates a more heterogeneous distribution of calcified plaques. Interestingly, we found no non-calcified plaques in patients with aortic stenosis, when in contrast, in the patients without this heart valve condition, the median was equal to 74.4. We also did not find lipid-rich plaques in patients with aortic stenosis, which indicates a lower risk of plaque rupture. And this leads us to the comparison of non-calcified plaques versus calcified plaques in our software. The areas highlighted in red are non-calcified plaques, and those on the yellow color are calcified plaques. So in conclusion, our study found a significant difference in plaque morphology within our study group between patients with aortic stenosis and those without. These changes may reflect on pathophysiological underlying mechanisms specific to aortic stenosis, which may imply in the future on risk stratification, treatment planning, etc. Thank you for your attention.
Thank you very much for your presentation. First, I would like to ask you about your contribution to the work.
Of course, so my contribution to this work was very broad. We came up with this aim and consulted this with our tutor and discussed how we can approach it. Then we proceed to collect database, the selection of patients based on criteria I mentioned before, which was the quality of their CT image scans and visually evident atherosclerosis. Then we analyzed this data using Autoplaque 3.0 software, which we had to learn how to do that, and then collected all the necessary data and analyzed it statistically by ourselves, and created this presentation for you. Thank you.
Actually, the groups are not very rich, so there is 30 patients in non-aortic stenosis and 30 patients in aortic stenosis. How did you select the patient with aortic stenosis? These were all patients with severe aortic stenosis, or patients just with degenerative lesion within the leaflet?
So the selection of patients with aortic stenosis, we selected the patients with severe aortic stenosis that were classified to who underwent TAVI, the procedure of TAVI. Okay,
so these were all patients with advanced aortic stenosis.
Yes.
So your results showed that the plaque in the patients with aortic stenosis was actually rich with calcium and lipids. Yeah, so because all three components were significantly higher than in patients with aortic stenosis. Am I right?
The patients with aortic stenosis have had more calcified plaques distribution than those without.
Maybe the answer to your presentation is an old description reported in last century cardiology handbook, Clinical Cardiology by Sokolov. It's Menkeberg arteriosclerosis. Please refer. Maybe this is the answer to your finding. Thank you and congratulate for the presentation.
Thank you so much.
Thank you for the discussion. Thank you for your presentation. And now I would like to invite so first I would like to say to the jury that presentation number 9, which is changes in circulating LPS, will not be presented today. So we can cross that one out. And we are presenting the 10th presentation, which is elevated baseline microRNA 92A as a predictor of cardiovascular events in chronic coronary syndrome patients by Maria Przeździecka.
Good morning, ladies and gentlemen. My name is Maria Przeździecka, and let me start off by saying that it is a great honor and privilege to stand here before you. Today, I will present the results of our study on the prognostic role of microRNA 92A in patients with chronic coronary syndrome. This study was conducted at the Medical University of Warsaw under the supervision of Dr. Michał Kowara. So, to begin, microRNAs are small non-coding RNAs that regulate gene expression by either silencing or degrading specific messenger RNAs. In recent years, their role in disease modulation and especially in cardiovascular pathology has attracted considerable attention. One of the key reasons for that is that they're remarkably stable in circulation, but also their expression patterns reflect specific cellular processes. So this makes them very promising candidates not only for diagnostics, but also for predicting outcomes in chronic diseases such as coronary artery disease. And just last year, their fundamental role in post-transcriptional gene regulation has been recognized with the Nobel Prize in Medicine and Physiology. So, in the context of chronic coronary syndrome, microRNAs play a dual role. They regulate both atherogenic and atheroprotective pathways involved in the progression of the atherosclerotic plaque. And two transcription factors really stand out in this regulation, namely Krupa-like factor 2 and Krupa-like factor 4, which are both essential for maintaining vascular homeostasis. KLF2 promotes the expression of endothelial nitric oxide synthase, supporting nitric oxide release, which is essential for vasodilation, antithrombotic activity, and suppression of vascular inflammation, whereas KLF4 complements this by maintaining endothelial quiescence and reinforcing anti-inflammatory gene expression. So this protective environment, however, can be disrupted by certain microRNAs, and in particular, microRNA 92A has been shown to directly suppress both KLF2 and KLF4. This downregulation diminishes nitric oxide availability, increases vascular inflammation, and promotes endothelial dysfunction, all of which are key drivers for atherosclerosis progression and plaque destabilization. MicroRNA 10B, on the other hand, has been found to downregulate KLF4 as well, suggesting a potential pro-atherogenic effect through suppression of endothelial protection. So, building on that idea, the aim of our study was to assess whether baseline levels of selected microRNAs could predict future cardiovascular events in patients with stable CCS. And our hypothesis was that changes in these microRNAs could serve as early warning signs of adverse effects in adverse outcomes in these patients. So we conducted a 2-year prospective follow-up study involving patients with chronic coronary syndrome. At baseline, we measured plasma levels of microRNA 92A and microRNA 10B, and then monitored patients for cardiovascular endpoints, including myocardial infarction, stroke, cardiovascular-related death. And because the data were not normally distributed, we used the Mann-Whitney U test and then presented results as median values with interquartile ranges. Our key finding was that baseline levels of microRNA 92A were significantly elevated in patients who later experienced cardiovascular events. This difference was statistically significant with a p-value of 0.036 and suggests that microRNA 92A could serve as a predictive biomarker. What's important here is that this elevation occurred before the events, so this makes it potentially valuable for risk stratification. On the other hand, microRNA 10B did not show any significant difference between patients who experienced the events and those who didn't. So while it may still play a role in vascular biology, in this particular study, it did not prove useful for prediction. So, to summarize, we found that elevated baseline levels of microRNA 92A were associated with increased risk of cardiovascular events in patients with stable CCS, which supports its potential as a prognostic biomarker. On the other hand, microRNA 10B showed no predictive value in our study population. There are some limitations, of course, which I will now address. First, the sample size was relatively small, which can impact both statistical power and generalizability. Secondly, our data did not follow a normal distribution, so we were required to use non-parametric statistical methods, which, while appropriate for this type of study, they can reduce sensitivity to detect subtle differences. Finally, but importantly, the majority of the cardiovascular events that we analyzed were so-called soft endpoints, such as cardiology-related hospitalizations. And while these are clinically significant, they don't carry the same weight as MACE, so major adverse cardiovascular events such as myocardial infarction or stroke. Here are some key references that informed our study, including recent reviews on microRNA therapeutics. And finally, I'd like to thank my supervisors and thank you for listening. I'll take any questions now.
Okay, thank you for your presentation. So I think the first question would be, what was your contribution to the work?
Okay, so the data were collected by my supervisor over the span of 2 years. Also, microRNA were extracted from plasma by him. My contribution was mainly in the follow-up, so we collected data about the patients, we analyzed it, we performed structured telephone interviews to interview the patients about the endpoints. We reviewed those endpoints and classified them either as no endpoints or endpoints, and then as either soft or hard endpoints. Statistical tests were performed, and then I made the presentation and previously wrote the abstract based on that. Thank you. Yeah.
Congratulations for a very pleasant presentation and for very nice longitudinal study. this is a example how the cause and effect study should be performed, designed and performed. Congratulations. And have you received any funding for microRNA analysis?
Not that I'm aware of.
Congratulations.
Thank you so much.
I would like to ask you about this prognostic marker. So, when it should be, this biomarker should be assessed to evaluate the prognosis of the patient?
I think for patients who might be at risk for chronic coronary syndrome because of various factors, if, of course, the study progresses and if it finds some clinical applications, then as early on as possible, microRNAs could be detected and assessed for that to for us to be able to implicate some measures to either prevent or treat chronic coronary syndrome as early on.
In other words, can we, do you think that we can use this marker as a marker of plaque stability, just to predict acute coronary syndrome?
Plaque stability, I'm not sure, to be honest. I think it's rather correlated mainly with progression of chronic coronary syndrome and and whether it comes about, not directly with plaque stability.
Okay, thank you.
Okay, thank you so much.
Thank you for the discussion, and now I would like to welcome the online presentation, Late Night Live Screen Time are associated with hypertension in the urban population by Gede Aswin Parasia Sasmana, Made Ayu Kerurnyati at Maja. Welcome, can you hear us?
Can you hear my voice?
Yes, we can hear you, and please share your presentation by sharing your screen with the green button on the
Can you see my screen?
Yes, we do see your screen. And when you're ready, you can begin.
Okay, thank you very much for the opportunity given to me. I'm Aswin Malaysia from Indonesia. And from the previous presentations, we are talking about the clinical cardiology sessions. And I would like to present another side of cardiology that I've been doing with my team, with my research team. This is the epidemiological cardiology. We assess the lipid meal and also screen time that is associated with hypertension in urban populations of Bali, Indonesia. I am Aswin Malaysia Sasmana.
I think the connection might have lost us. Can you repeat, please? Maybe we will go to the next presentation while we reconnect. So we would like to welcome presentation number 11, which is Coronary Artery Anomalies, Holter ECG Study by Alexandra Korus and Dariusz Kucias.
Good morning, ladies and gentlemen. My name is Alexandra Korus, and I would like to present the study entitled Coronary Artery Anomalies, Holter ECG Study. Let's start with the basics. Anomalous aortic origin of a coronary artery is an anomaly of the anatomy in which coronary arteries arise from a different spot and thus have an abnormal course. This disease is very rare in the general population and can be asymptomatic or can have different symptoms, often resulting from impaired perfusion of the myocardium, causing, for example, symptoms of ischemia or even sudden cardiac death, especially in undiagnosed athletes. Normally, obviously, the heart is supplied by two arteries, the right artery, which supplies the right ventricle and the posterior part of the heart, and the left artery, which bifurcates into the circumflex artery and the left anterior descending artery. For this study, we have assumed this classification, which classifies the anomalies into 5 types, depending on their course. So we have the prepulmonic, the interarterial type, which is said to be the highest risk of adverse events. The subpulmonic, the retroaortic, which is the most prevalent type, and the retrocardiac, which is very rare. The aim of our study was to assess the types of heart rhythms in patients who have had Holter monitoring, especially in relation to atrial fibrillation. To achieve this, we analyzed over 1,600 CT scans, searching for the phrase coronary anomalies, and we have found 102 of them. Then we included 49 patients who have had Holter monitoring in addition to that, and we excluded patients who were under 18. And we analyzed the results in relation to main rhythm and symptoms, and we compared the Holter data with the type of the anomaly. The study group finally consisted of 45 patients, of which 14 were females, and the ages ranged from 21 to 87, and the group followed a normal distribution. About the anomalous arteries, the most prevalent type was retroaortic, 21 patients, followed by interarterial, then 1 prepulmonic, and the rest were unknown because they were not, it was not possible to classify them according to this classification, which was quite simple. In the Holter results, the most prevalent rhythm was the sinus rhythm, obviously, followed by atrial fibrillation, and then 1 patient had ectopic atrial rhythm, and 1 had pacemaker-induced rhythm. Then we analyzed the patients with atrial fibrillation and analyzed the causes of their anomalies. 2 patients had retroaortic type, 1 had interarterial, and 1 had prepulmonic. Because most patients had retroaortic type, we have performed a Fisher's test to determine whether the prevalence of atrial fibrillation is higher in the patients with this type, but no correlation was observed. But we know that the sample size is the limitation of our study, and probably more patients should be included in the groups in the future. However, it is difficult to find patients with this combination of diseases. And to sum it up, AAOCA are congenital, can be isolated, or can be a part of other groups of anomalies, such as transposition of the great arteries or tetralogy of Fallot. And therapeutic options include, obviously, surgical treatment, but only in patients who are symptomatic or are of high risk. We can also treat them with beta blockers. This is according to recommendations of American Society of Thoracic Surgeons. Also, if the patient is operated on, for example, because of this anomaly, according to the recommendation, left atrial appendage closure can also be performed to decrease the risk of thromboembolic complications. But the most important conclusion is that the influence of AAOCA on atrial fibrillation or other heart rhythms is not yet well understood, mainly because this anomaly is quite rare and there aren't many studies conducted. Thank you for your attention. And for the contribution, I would like to say that I contributed to all parts of the study that was collecting the data from electronic records of the patients, analyzing the data, then statistical analysis, and obviously creating the abstract and the presentation.
Thank you for the presentation, and now we will begin the 3-minute discussion.
Is related to the practical, potential practical application. Do you think that we can, in practice, use ECG Holter to scan patients with suspicion of congenital anomalies, coronary artery anomalies?
I would maybe say the other way around. If a patient has a coronary anomaly, they are probably of higher risk of developing abnormal rhythms. For example, I know that ventricular tachycardia is considered important in this if a patient has a coronary anomaly.
Okay.
Congratulations of tremendous work. You have screened over 10,000 CT scans looking for coronary artery anomalies. Great work, congratulations.
Thank you.
And if there are no more questions, we will continue with the next work, which is non-invasive assessment of pulmonary hypertension severity with focus on electrocardiographic changes by Krystian Domarecki, Mateusz Stępień, Marta Strauchman, Daria Nowak, Filip Chodań, and Julianna Stachaczyk.
Good morning. Good morning, ladies and gentlemen, dear jury, fellow students. My name is Krystian Domarecki, and today, as a representative of First Department of Cardiology, Medical University of Silesia, I'd like to present our study called Non-Invasive Methods of Assessing the Severity of Pulmonary Hypertension, with particular emphasis on electrocardiographic changes. As we know, pulmonary hypertension is a progressive and rare disease characterized by elevated pressure in pulmonary arteries. Early identification of this disease is crucial for guiding therapeutical decision. Although right heart catheterization is a gold standard for diagnosing and assessing the severity of this disease, it is an invasive and resource-consuming procedure. Therefore, there is a need for non-invasive methods that can be helpful for medical providers in this field. The aim of this study was to characterize patients with PH using non-invasive methods of disease severity assessment. So we intended to collect clinical data like laboratory data, 6-minute walk test, transthoracic echocardiography, and especially electrocardiographic features that could distinguish a patient with less severe and more severe PH course. We enrolled 98 patients diagnosed with PH who were hospitalized in our center. All of them underwent right heart catheterization to assess mean pulmonary artery pressure, also called as MPAP, which we used as the basis for stratification in this study. We divided our patients into groups according to the MPAP. The first one, including patients with MPAP below 45 millimeters of mercury, and the second one, including patients with MPAP equal to or above 45 millimeters of mercury. For each patient, we assessed a broad range of parameters, but today I want to highlight the statistically significant data, meaning those with p-value of less than 0.05. In our study, the two subgroups did not differ significantly in terms of age or sex distribution. However, patients with higher MPAP demonstrated several important differences, like laboratory differences. We can see that laboratory results show us significantly higher hematocrit and elevated NT-proBNP levels in the second group, what reflects a higher hemodynamic burden of these patients. Another important parameter was HDL cholesterol level, which was significantly lower in patients from the second group. The box plot shows us the echocardiographic values across 6 different parameters. Notably, the second group exhibits lower median values for TAPSE, LA area, ECT, and also RV-FAC. Meanwhile, the same second group had a higher median values for RA area and TPG. In patients with advanced PH, meaning those from the second group, changes in their ECG were more frequently seen, such as right axis deviation greater than 110 degrees, P-wave amplitude greater than 1.5 millimeters in lead V1 or V2, and T-wave inversion in lead AVF. There is an example of one of ECGs of our patient from the second group, and you can see over here that there is P-wave amplitude greater than 1.5 millimeters in lead V2, and also there is a T-wave inversion in lead AVF. There is also a right axis deviation on this ECG. Interestingly, we also succeed in identifying several other statistically significant data concerning persistent atrial fibrillation and statin usage among our patients. Specifically, the occurrence of persistent atrial fibrillation and statin therapy was higher in the first group compared to the second. Among other data, we also observed that people from the second group had a higher BMI index. As previously mentioned, the patient with PH also underwent a 6-minute walk test, which revealed worse oxygen saturation post-exercise in the second group. This has been now strongly associated with more severe disease course of PH. In conclusion, our study shows that certain parameters can serve as simple and effective indicators of severity of PH. Of course, as we know, invasive investigation are essential for establishing the diagnosis according to the Polish Cardiac Society. However, non-invasive low-cost tools such as echocardiographic parameters and standard 12-lead ECG can certainly be used for monitoring disease progression or guiding pharmacological escalation, even in ambulatory patient care. These are our references, and on behalf of our research group, I'd like to thank you for listening to our presentation, and now I'm available to answer any questions you may have. And also my contribution to this work, firstly it was both me and my friends. We create a database, then we collect all the necessary data from both electrical from the hospital database and paper database, including ECG from the hospital. We analyze all the ECGs by ourselves. Our tutor helped us with statistic work, and we create this presentation today. If you have any question, free to ask.
Congratulations on the presentation and the work. But do you think that ECG monitoring can predict the pulmonary hypertension reversibility?
It's really hard to say. We have to look into more studies to decide whether it's possible to see the reversion of this disease. But for sure, it's not. It's a good way to predict whether the patient with PH, the course of their disease, are worsening or not. So, as I said, even in ambulatory care, we can use these tools for to help medical providers.
But my question is, the ECG changes you have showed us reflect a pulmonary circulation pressure that lasts for months, years, or even longer. And they are the typical handbook changes you have discussed and showed us. But when we perform invasive reversibility test, either with nitric oxide or even sildenafil, nitroglycerin, nitroprusside, we have the answer within few minutes if the pulmonary hypertension is reversible and how to treat the patient.
We didn't take this into consideration in our study, but definitely we could see some differences in ECGs when the patient is under pharmacological therapy. For example, the right heart overload can cause the right heart axis deviation, and after the therapy, this right heart axis deviation might be less significant.
Thank you for your presentation. I wonder, what did you use this pressure criterion, dividing the patient with mean pressure below 45 and over 45? Because I think that ECG morphology is equally affected not only by the changes on the right heart, but also by the changes of in the morphology of the left heart. So maybe it makes sense to look at the different types of pulmonary hypertension. I mean, left heart induced or primary hypertension?
Yes, we exclude all the patients who had recent cardiovascular diseases like myocardial infarction or pulmonary thrombosis. And answering to your question why there is a threshold of 45 millimeters in MPAP, we did a literature review and seen that there is a lot of studies that suggest that the threshold of 45 for MPAP suggests that patients above 45 are having more severe course of PH. So we decided to create these two groups according to other studies. So we decided this threshold will be 45 millimeters.
Okay, thank you.
Thank you.
Thank you. We have now run out of the time for the discussion, and I would like to welcome the next presentation, which is Myocardial Strain and Work in Patients with AMI on Cardiovascular Outcomes, a retrospective analysis by Barbara Gurba, by Alicja Pawlus, Kacper Kolebacz, and Marta Jędrzejowska. Sorry for the mistake. So this is presentation number 13 on the jury card.
And today I would like to present you the topic we've been working on, which is myocardial strain and work in patients with severe aortic stenosis and mitral regurgitation undergoing TAVI. Our work's tutor are Associated Professor Witold Strep and Professor Beata Średniowa. At the beginning, the aortic stenosis is the most common valvulopathy nowadays that describes narrowing of the opening of the aortic valve, which involves 45% of patients around 8 years of age. The treatment of aortic stenosis is surgical or transcatheter aortic valve replacement TAVI. And the common coincidence associated with aortic stenosis is mitral regurgitation. In patients with aortic stenosis and concomitant mitral regurgitation, we observe a reduction in afterload and stroke volume. This effect is also further exacerbated by left ventricular hypertrophy, contributing to a decreased preload. These hemodynamic changes are associated with coexisting MR, may have significant prognostic implications. The clinical utility of myocardial work assessment has been validated across various cardiac pathologies, for example, aortic stenosis. Our aim of the study is an assessment of myocardial work in patients with severe aortic stenosis and mitral regurgitation undergoing TAVI. Our study cohort consisted of 95 patients with a mean age of 79.1 years, and among the patients there were 45 women and 50 men. The echocardiography was performed in all patients using Vivid E95, and the analysis was carried out at the EchoPac station. As for myocardial work parameters, we analyzed global constructive work, global wasted work, and also global work efficiency. The statistical analysis was performed during using the Yamovi software. Quantitative variables were expressed as mean, categorical variables were presented as counts and percentages, and the p-value of below 0.05 was considered statistically significant. When it comes to results, the mitral regurgitation was identified in 2/3 of the study population, and according to the Carpentier classification, type 3A was the most prevalent, and it was observed in 39 patients, while 19 patients, remaining 19 patients exhibited type 3B. Also, the most frequent regurgitation in our study population was mild regurgitation, which was presented in 39% of our patients. This is the table that shows characteristics of the study group. However, there were no statistically significant differences in demographic data or concomitant diseases between patients depending on the degree of mitral regurgitation. In this table, we can show echocardiographic findings according to the degree of mitral regurgitation. Significant differences were observed in left atrial size and left atrial area, and these parameters were highest in the group with severe MR. Also, E-wave velocity was increased significantly with the severity of MR. Results of myocardial strain and work show that the only parameter that was significant was global constructive work. And the lowest, what is interesting, the lowest global constructive work value was observed in patients with severe mitral regurgitation, and the highest value was observed in patients with moderate mitral regurgitation. To sum up, global constructive work demonstrated significant differences between groups. The lowest value of global constructive work was observed in patients with severe mitral regurgitation, whereas the highest value was recorded in those with moderate mitral regurgitation. And the global wasted work did not differ significantly between groups, nor did global wasted work. To conclude at the end, the findings indicate that while parameters such as global longitudinal strain, global wasted work, and global work efficiency remain comparable across patient groups with varying degrees of MR, the global constructive work may serve as a more sensitive indicator of changes in cardiac function in relation to MR severity. And thank you for your attention.
Thank you for your presentation, and now I would like to begin the discussion with asking about your contribution to the work, and then we'll begin with the jury questions.
Of course, so my contribution, at the beginning we had to choose the topic for our presentation and for our work. Then we collected patients' data, and then we took part in the echocardiography analysis. At the end, we made an abstract and made this presentation.
Congratulations for your work. These parameters are actually extensively analyzed, and this is an interesting group to look at the impact of concomitant mitral regurg. How would you explain these differences between the group with moderate and severe MR?
I think that the value was increasing from the mild to moderate global constructive work because of the compensatory mechanism, while when the mitral regurgitation became severe, the mechanisms that work previously, then they fail.
Actually, only the constructive work showed the differences, but the wasted work didn't. Are you surprised with these differences?
Maybe not surprised, because our study population I think was too small, but we are currently working on expanding our database because in other studies we've been searching on also global constructive work and global wasted work made some differences between study group depending on the degree of mitral regurgitation. So I think that maybe when we have more patients, the results will be different.
Okay, thank you.
Congratulations on the work.
Thank you.
Best regards.
Thank you.
Thank you for the discussion and thank you for the presentation. Now we will begin with work number 14, which is ARNI versus SAE-ARB in patients with AMI on cardiovascular outcomes, a retrospective analysis by Barbara Gurba, Monika Bujak, Katarzyna Chowoniec-Rybka, Magdalena Sowier, and Martyna Nowak. And just a reminder that we have 7 minutes, and again, at the end, please mention your contributions so that we have a quicker discussion.
Good morning, ladies and gentlemen. My name is Martyna Nowak, and today on behalf of our whole team, I have the privilege of presenting to you our research titled ARNI versus ACI-ARB in patients with AMI, cardiovascular outcomes, a retrospective analysis. Excuse me. Firstly, I'd like to provide a little background on what ARNI actually is. ARNI stands for angiotensin receptor nephrolysin inhibitor, which represents a modern class of pharmacological agents used in treatment of heart failure, particularly in patients with reduced ejection fraction. It combines two complementary mechanisms, one being a nephrolysin inhibitor, the other one being angiotensin to blocker. According to 2021 ESC guidelines, it holds a class 1 recommendation for management of patients with heart failure with reduced ejection fraction and class 2B recommendation for management of patients with heart failure with moderately reduced ejection fraction alongside ACI and ARB. Use of ARNI in acute myocardial infarction was studied already in the Paradise MI trial, which was published in 2021. It observed the reduced risk of pre-specified major coronary composite outcome of ARNI compared to Amipro, as well. Additionally, echocardiographic sub-study also showed beneficial effects on cardiac structure as well as function after ARNI treatment. The use of ANI in acute myocardial infarction was also tested in animal model. In this study, the rabbits after AMI were treated with either placebo, valsartan, or ANI for 4 weeks, and as you can see in panel C, the group after ANI treatment had the biggest improvement in LVEF. It also turned out that ANI increases the inducibility of ventricular arrhythmias such as VT and VF. The aim of our study was to compare the efficacy of ANI with ACI ARB therapy in patients with first AMI for cardiovascular outcomes and post-infarction left ventricular systolic dysfunction. Overall, 1,572 cases with AMI diagnosis hospitalized from January 2022 to December 2024 in the first department of cardiology, Medical University of Silesia, were enrolled into our retrospective cross-sectional analyses. The outcomes analyses consisted of LVEF in 6 weeks and 4 months follow-up, as well as cardiovascular outcomes in 1 to 3 year follow-up. We included patients who were 18 years or older with a diagnosis of myocardial infarction, who underwent percutaneous revascularization of the infarct-related coronary artery and complete revascularization during current hospitalization, with post-infarction left ventricular systolic dysfunction of 40 or less, and were enrolled in coordinated specialist care after MI. Called program COS-ZAVA, we excluded the patients with history of previous myocardial infarction or coronary vascularization, a history of heart failure or angioedema, severe hepatic or renal dysfunction, coexisting severe diseases of the immune, hematopoietic or respiratory systems, or systemic diseases, presence of malignant neoplasm, or had an incomplete clinical data in the medical record. Overall, we analyzed, in the final analyses, we included 1,572 hospitalizations with AMA diagnosis. We included identified 1,461 patients, 990 of them were men, which made up 67.8% of the whole study group. Median age was 71. After applying the inclusion and exclusion criteria, 1,385 patients were excluded, mostly due to previous AMIs or heart failure history. In the final analysis, we included 76 patients, among which 30 were treated with ANI and 46 were treated with ACI or RAB. To minimize the baseline differences between the treatment groups, we applied propensity score matching. Taking into regard age, gender, as well as LVEF of both subgroups, matching was performed using one-to-one nearest neighbor method without returning. The matching resulted in 2 subgroups with 30 patients each, where the age, gender, LVEF proportions were more comparable. In the results, so patients in both subgroups were quite similar clinically. There were no statistically significant differences. The mean age was about 60. The BMI was about 29. 80% of patients in both study groups were diagnosed with STEMI, and there were no statistically significant differences in basic laboratory tests. In the ARNI subgroup, the initial LVEF was notably lower, although not statistically significant. The comorbidities were also quite similar. Most of the patients additionally suffered from hypertension, lipid disorders, or had a history of nicotine addiction. When it came to pharmacotherapy, it was also quite similar. The only statistically significant difference was regarding SGLT2 inhibitors, which were more likely to be used in the ARNI subgroup. In the 6 weeks follow-up, there was a substantial improvement in both subgroups, and in 4 months follow-up, the improvement was significantly higher in the ARNI subgroup. It went from 30, the median LVEF went from 30 to 40%, which made delta Delta percentage 33.33%, and in the ACI group it went from 38 to 48, which made delta percentage 23.68. To conclude, our current experience in ARNI therapy after AMI is limited to a small group of patients with significantly reduced LVEF. However, ARNI therapy is non-inferior to conventional ACI ARB therapy and significantly improves LVEF in 4 months follow-up. ARNI after recent myocardial infarction is used more and more often, but further research is of course needed. Thank you so much for your attention. My contribution to the work was mostly during the preparing of the database and analyzing the database.
Congratulations for your work. A couple of questions. This data comes from the one center, or this is a multi-center?
This is a one-center study.
One single center. From which time period the data were?
From January 2022 to December 2024.
Because the current practice is that once we know the benefits of using ARNI in early phase, even after myocardial infarction, more and more clinicians are using these drugs. Of course, the final number you were that you were comparing was relatively small, so it's difficult to conclude definitely that the differences actually between those groups of important agents are not significant. I mean, the problem is that if you would take the data from the last, let's say, last 2 years, you will find out that majority of patients is treating with ARNI at early phase of myocardial infarction.
We also took into consideration 1 to 3 year follow-up, which I didn't manage to squeeze into the presentation. The follow-up consisted.
And also the follow-up was relatively short, yeah?
Yeah. 4 weeks, 6 weeks, 4 months, but also in COS program. And in that follow-up, we evaluated that 1 person from the ARNI group died and 2 people from the ACI group died, and also as there were no rehospitalizations in the ARNI group needed, but there were 3 rehospitalizations needed in the ACI group due to either the decompensation of heart failure or reinfarction.
Now we have unfortunately run out of time for the discussion, so
just very short comment.
Short question.
Congratulations, you have used matched pairing for patient population selections. Congratulations.
Thank you.
And now I would like to welcome the presentation Impact of Obesity, T2D, and Dyslipidemia on Pacemaker versus Ablation Choice in Tachybrady Syndrome by Marcin Cwynar, Dominik Dubiński, Natalia Godela, Michał Ciszek, Mikołaj Tyla, and Rim Mohainsen.
So good morning, ladies and gentlemen. My name is Rima Mohainsen. I'm a 5-year medical student. And today I'm honored to present the results of our research conducted by First Cardiological Department at the GCM Hospital in Katowice under the supervision of Professor Mija Stec and Dr. Bartosz Gruchlik. The title of our presentation is Impact of Obesity, Type 2 Diabetes, and Dyslipidemia on Pacemaker versus Ablation Choice in Tachycardia-Bradycardia Syndrome. So first of all, I want to explain what is the tachybrady syndrome, and it is defined as a rhythm disorder classified under 6 sinus syndrome, SSS, and it is characterized by alternating episodes of supraventricular tachyarrhythmia, predominantly paroxysmal atrial fibrillation or a flutter, bradycardia, and sinus pauses. It can be related to alternating stimulation or suppression of the heart rhythm because of age-related degeneration, ischemia, or fibrosis. Also, it can be impaired automaticity when the sinoatrial node fails to properly initiate the heart rhythm. The tachybrady can be caused by cardiomyopathy, some kind of medications such as digoxin, amiodarone, or beta blockers. Sometimes it could be a post-ablation treatment or kind of failing of the sinoatrial node. We should be aware of the fact that this syndrome significantly impairs quality of life and elevates the risk of cardiovascular events such as stroke or heart failure. The traditional treatment includes pacemaker implantation. However, the recent studies show that the ablation will increase the quality of life, offering an alternative therapeutic strategy. When it comes to the symptoms of the tachycardia-bradycardia, it can be weakness, palpitation, dizziness, syncope, or a presyncope. Of course, depends on if we have the bradycardia more or the tachycardia. Here we have an illustration of the electrocardiogram, and this is a supraventricular tachyarrhythmia. So here there is supraventricular tachyarrhythmia in the tachybrady syndrome, and there is an irregular air waves and the absence of P wave, which supports our interpretation. When it comes to the aim of our study, we decided to see if these metabolic changes will affect the treatment, if we'll only rely on the scatter ablation or on the pacemaker implantation. And we all know that cardiac patients are more likely to represent metabolic difficulties that may worsen the clinical outcomes. When it comes to the materials and methods, we retrospectively analyze 70 patients from the first cardiological department at the GCM hospital in Katowice, and all of them represent the tachycardia-bradycardia, and 62 out of them received device implantation, 21 undergo catheter ablation, and 30 received the both treatment. And also we analyzed the cardiovascular data, the cardiovascular risk event, the type of prescribed medication, the patient's medical history, and the biochemical data. And as I said before, we stratified them into 3 groups: the catheter ablation only, the device implantation only, and both treatment. When it comes to the results of our study, we found that patients who underwent ablation were significantly younger than those with pacemaker implantation, in a mean age 62.9 compared to 80.4 respectively. So we just can see that there is a statistical signification between the chosen treatment and the age of the patients, because the p-value was under the 0.05 threshold. But when it comes to the BMI, hyperlipidemia, and dyslipidemia, there is no statistical significance between these metabolic changes and the type of chosen treatment. So we just know that the treatment should be chosen by the patient's electrophysiological profile and the variety of the arrhythmia, not only on these metabolic changes. And we decided to calculate the mean age of the patients because the data distribution appeared to be approximately normal without significant outliers. And when it comes to our conclusion, our findings show that these metabolic comorbidities, such as obesity, type 2 diabetes, hyperlipidemia, do not significantly influence the choice between pacemaker implantation and catheter ablation in patients with tachybrady syndrome. And as I said before, it should be mainly guided by the electrophysiological profile of the patient. And thank you for your attention, and I'm free to receive any questions. And when it comes to my work and my part of the job, first of all, we consult our work with our tutor, and we just see the similar researches about it, and then we retrospectively analyze all of the data at the GCM hospital. It was quite hard for us to find these patients because the tachybrady is not listed on the ICD-10 list of diseases, so we just have to manually search for them using the AMS program. I know that our limitation of the study is the small group research of patients, only 70, but it was very hard for us to find them. So we know that if we have larger research group, our results may be different. And thank you.
My question is, what is new in your work? Because last year and 1 month ago was announced a statement and guidelines on pacing 1 year ago. And it is clear evidence that in such patients with tachybrady syndrome, much better is to ablate tachyarrhythmia than at first implant pacemaker. So please explain what new is, what add your work to this knowledge.
Like as I said before, like the younger patients are more likely to receive the ablation because of that we are increasing the risk of some kind of infections or we also decrease the need of the pharmacological treatment if we come to compare to the pacemaker implantation. And that's all, I think.
This is the confirmation of current statement, yes. But it is also clear that older patients demand pacemaker implantation rather to ablate the arrhythmia.
As I noticed, the group who was referred for ablation, this was actually the group with the higher BMI, so more obese patients. How would you explain that?
Like as I said before, like there is no specific like correlation between like these metabolic changes and the type of chosen treatment. So it will only rely on this electrophysiological profile of the patient, not like for this like obesity or high BMI or I don't know, dyslipidemia.
Was effective? Was the ablation effective?
Yes,
in these patients?
Like the ablation is more effective because like there is less invasive, so it's much better for the younger patients, and also like the younger patients are more likely to represent the tachycardia changes when compared to bradycardial changes. So, and also like the catheter ablation also like treat the cause and not only masking the symptoms. So that's more effective than the pacemaker implantation.
Did you analyze any outcome measures? I mean, the quality of life in this patient?
Like we measured like the cardiovascular risk event, the biochemical data, the prescripted medications, and the patient's medical history. And like that's all.
Okay, thank you.
Thank you.
We are
out of time for the discussion, so if there are no more questions, then I would like to thank you for your presentation. And I would like to welcome our final presentation, which is the online presentation for the jury. This is number 11 in your book. This is actually, we have still one left on stationary 17, which is the influence of CT vendor on aortic valve calcification measurements by Weronika Nowicka and Julia Dudek. So if I may welcome you to the stage.
Ladies and gentlemen, my name is Weronika Nowicka, and today I would like to present you our study titled The Influence of Computed Tomography Vendor on Aortic Valve Calcification Measurement. Let me begin with a brief introduction, the clinical context of this presentation. Aortic stenosis. It is a valvular heart disease characterized by the constriction of aortic valve opening. The narrowing impairs normal blood flow into the aorta, often causing significant clinical consequences and a higher risk of mortality. Therefore, an accurate assessment remains crucial for determining optimal treatment strategies. Echocardiography is considered as a gold standard for the diagnosis. But sometimes the severity remains uncertain, and in such cases, computed tomography offers valuable additional insight. However, a key concern is that previous studies have shown existing discrepancies in the Agatston score when evaluating vascular classification using different vendor-specific systems. With that in mind, the aim of our study was to examine the role of vendor-neutral Agatston score in the classification of patients with indeterminate aortic stenosis severity. We conducted a single-center retrospective analysis, including 100 patients with severe aortic stenosis confirmed in the echocardiography, among whom 50% were women. Evaluation of Siemens computed tomography scans was performed at the Department of Cardiology and Structural Heart Diseases in Katowice. Calcification was quantified semi-automatically using the Agatston method in Syngovia imaging software. And as you can see, here is an image presenting the analysis process of aortic valve, in which we manually marked the calcification. Then, for each patient, we applied a previously developed calibration tool, the vendor-neutral Agatston score, that was obtained from its creators. It showed to improve cardiovascular outcomes. We used two regression equations. The first one for overweight or obese patients. The second one was used in patients with the BMI below 25. Patients were categorized into 3 probability groups of severe aortic stenosis based on computed tomography aortic valve calcium measurements, presenting the groups of unlikely, likely, and highly likely. Now let's examine the results in the greater detail, starting with the baseline characteristics of the study population. So, the mean age in females was 78.02 years, and in males, 76.3 years. Initially, the median Agatston score among women was 2,111.8, and in men, 2,522.7. But after we apply the vendor-neutral Agatston score, the median values rose, as you can see, to 2,393.1 in women and 2,993.5 in men. So, for both female and male groups, the p-value was less than 0.05. After comparing the vendor-neutral Agatston score and Agatston score, which indicates statistically significant difference after recalculation. This image shows how the reclassification looks. So, based on vendor-neutral Agatston score, 28.6% of women were reclassified from likely to highly likely group to have severe aortic stenosis. In men with vendor-neutral Agatston score recalculation, 27.3% were reclassified from unlikely to likely, 16.7% from likely to highly likely, and 5.6% moved downwards from likely to unlikely. Moving on to the conclusions. In total, 8% of all women and 14% of all men were reclassified into another probability group 2 of severe aortic stenosis based on vendor-neutral Agatston score. So our findings suggest that previous studies and the vendor-neutral Agatston score may improve aortic stenosis definition in patients with suspected severe aortic stenosis, and also potentially improving the diagnostic precision. Thank you for your attention. I'm happy to answer any question you may have.
Thank you for your presentation. I would like to begin with asking about your contribution to the work.
Okay, so our contribution started when we discussed the aim and the topic with our tutor, and then we reviewed the CT scans and we analyzed cardiac computed tomography images. And as I mentioned before, we manually marked the calcification. After that, when we had the Agatston score, we applied the vendor-neutral Agatston score calibration tool, and we saw how the recalculation looks. We performed the statistical analysis using the Statistica software, and then we prepared the abstract and today's presentation.
Could you characterize the group of patients with aortic stenosis you used for the analysis? Because we know that actually we have the problem with classifying the severity of stenosis in about 30 to 40% of our patients, specifically where the echo measures are discordant. Then we use the CT to calculate the CT's, the calcium score of aortic stenosis. So what was the characteristic of the group you analyzed?
Okay, so we used the patients that were in the waiting list for the TAVI, and they were meant to be discussed by the heart team. So the general population had severe aortic stenosis, but I need to say it was the proof of concept study. So it was the first stage of our research, and we focused on the general population of patients with severe aortic stenosis in the waiting list for the TAVI. But we are planning to expand our research to find more patients with main focus on echocardiographic findings, and with the patients with the discordant echocardiographic findings. And then we want to apply the extended group of these patients and analyze how would it be, because the key point of this study was to assess whether the vendor-neutral Agatston score has the impact of on the Agatston score in these cases with severe aortic stenosis, because the previous study was had the main focus on coronary arteries. So that is why.
Okay, thank you.
If there are no more questions, then we have run out of this discussion time. So thank you for your presentation, thank you for your discussion. And now we should be able to see the online presentation, late night, light meal, and increased screen time are associated with hypertension in the urban population. This is number 11 on the jury book. And we have, can you hear us?
Yes, I can hear. Can you hear my voice?
Okay, if you can please share your presentation and then we can begin.
Very sure. Can you see my screen?
Yes, we can see the screen.
Okay, thank you very much for the opportunity that is given to me. Let me start the presentations. Good morning, ladies and gentlemen. I'm Aswin Barisha. I'm the third year's medical student from Bali, Indonesia, who would like to present our research under the title of Late Night Light Meal and Increase the Screen Time are associated with the hypertension in the urban area of Bali, Indonesia. Here, I am the team leader of our research group, and we would like to give the information about the epidemiological side of the cardiology itself. We do understand that hypertension has become a global problem with a global prevalence reached to 23% of the general populations and involve more than 90% of the global death. And we do understand that this kind of disease increasing the risk of another high mortality and morbidity disease, including stroke and the other. Hypertension as one of the metabolic syndrome, it is involved in two kinds of the system, one of which is the calorie intake and the second, energy expenditure. And both of these sides will involve in the lifestyle. In today's, we have the demographical shift and we have the lifestyle changes around the populations. I am in the developing country, Indonesia, really found that this kind of the lifestyle changes really means a lot to the changes of the disease trends in our country. The lifestyle changes involve in calorie intakes and also in energy expenditure. On the calorie intakes, in the current populations, we see that a lot of the young generations do the late night meal behavior and also increase the screen time. Late night meal behavior increasing to the disturbance of the calorie intake and increase of the screen time can be seen as the less of the energy expenditure or less physical activity that is done by the general populations. That's why this kind of the study aims to evaluate the association between this kind of the two lifestyle changes in the today's populations with the hypertension in urban area in Bali, Indonesia. So this is the map of Bali. If they were understand of our area, we have a lot of the regions right here, and we do the multi-center epidemiological study involving Klungkung, North Denpasar, and South Denpasar with this kind of the populations per kilometer. And also, we do in the tree of the urban area, we define urban as the locations that have populations more than the average populations in the whole Bali itself. So we do the structures questionnaires to the personalized factor, including the frequency of the late night light meal behavior and screen time per day, and also physical examination of blood pressure. Then the data is analyzed bivariately. This is the general characteristic of the data that we can show you. The first one is the characteristic of the hypertension itself. We found that in the urban populations, we have 37.5% of the populations have the hypertensions, and this kind of the hypertension also associated with several risk factors. First is the higher age. Second is the more smoking cigarettes per day, and the third one is the bigger waist circumference with each kind of the its significant value of P value itself that you can see on the screen. This is the main characteristic things that we can report on this kind of the research. The first one, we found that the person or patient with hypertension have more likely to have late-night light meal behavior compared to the normal tension. Or the second one, this kind of the person with hypertension also have the increase in the screen time compared to the normal tension with the p-value up to 0.005. So this means that there are the significant mean difference between these two populations. On the discussions, we can see that the late night eating behavior is significantly involved in disturbance of the circumferential rhythm or circadian rhythm, that also increasing the metabolic stress and increasing in the cortisol level in the chronic times at all, and it also possible for this kind of the conditions. So this actually is the small portion of our big research. But when I see this kind of the result, it is really interesting that we found such an interesting relationship between these two things. Moreover, the snack or the light meal itself tend to have high sodium and also saturated fat that also can cause hypertension, and in line with the previous study conducted by Yoshida in 2019. The second one, this increase of the screen time also associated with the less of the physical activity and increase of the lifestyle and increase of the sedentary lifestyle, with also involving in optimal circulation, fluid retention, and also metabolic disturbance, and end up with the hypertension itself, as also in line with the previous study conducted by Wu et al. We also discovered that this kind of the hypertension also related to the older age, central obesity, and also smoking that we already know and have already well established. So in the conclusion, we can see that respondents with hypertension have more frequent light meal behavior and higher screen time in the urban populations of Bali, Indonesia. That's all of our presentations. I open to the question sessions. Thank you very much for the opportunity.
Okay, thank you for your presentation. I would like to ask about your contribution to the work.
Thank you very much. I am the team leader of our works. So in Indonesia, the research is not widely established as in the developed country. So when we do this kind of the work, we need a lot of effort, like ethical and also the place survey. We survey where's the urban area first, and we also dealing with the community because it is really difficult to gather the community because it is not the secondary data. We go to the community, to the urban area. So I am the team leader. I have the concept of this kind of the study. I'm involved in the questionnaire making and also validations of the questionnaires. I also involved in data gathering, data analyzing, and data reporting, and the finalizations, the finalization review of our studies. Thank you very much.
For questions from the jury, we have 2 more minutes for the discussion.
Thank you.
I would like to congratulate you for the concept of this work. However, the number of responders is rather limited. Only 48 person responded to a questionnaire. I think it is important that you point out the value of this behavior, light behavior, style of life. We do know that hypertension is an entity which is affected by multiple variables, not only the lifestyle, but these two this behavior concept, I think, is very important. So congratulate anyway, and I think that you should continue this work because we know that very simple parameters like, for example, number of steps we perform every week are also very powerful predictor of cardiovascular mortality. I think that this parameter you discovered are worth to investigate in a broader population.
Thank you very much. I would like to clarify the first about how I value this kind of the behavior by the structure interview. So the late night light meal behavior is defined as the persons who eat light meal, not like a rice on the main for the whole country, 3 times before bedtimes. So we do the structurized interview for the several times for several sessions in the populations that we observe. And thank you very much for your appreciations.
Okay, and now we have run out of the discussion time, so thank you for your presentation, thank you for the discussion, and I would like to say that all the submitted papers have been presented, and we congratulate all the presenting authors and participants of the non-invasive cardiology session. At this point, I would like to ask the president of the jury for a few words to sum up the session, if I may ask Professor Tomasz Kukulski here.
It was again a privilege for me to be here and have opportunity to hear the results of your work. And I think that this year we see again the high quality of your work. I must say that the topics are all the topics are very impressive and cover different areas of research, starting from imaging, and there was a lot of clinics in your presentation, and of course a lot of topics related to electrotherapy, coronary heart disease, heart failure, pharmacotherapy. So we see that your tutors simply want to involve you in different areas of also clinical work. It is very important that you did a step into the clinics. The quality of your presentation, I think, is good. And I think in most of the cases is sufficient to present the data also out of Poland at other international meetings. So I will encourage you also to present the data at different meetings. And I think that you should not give up in exploring your local databases. We know that at our university we will have an opportunity also to have an access to cardiology database because, as you know, the research cardiology network was established, so I think that you should ask your tutors also to use the data from our Silesian cardiology network. This is another source of interesting data. So do not give up. Please continue your work, prepare the next and new work, and prepare the new abstracts for the next meetings. Thank you.
Thank you very much for these motivating words. We truly appreciate both the contributions of our authors as well as the contribution of the jury, which have been so kind to come here today and assess your work. We would like to, at the end, cordially invite everyone to the decoration and closing ceremony of the SIMC 2025 conference, which will be held here in this A3 hall on the 9th of May at 5 p.m. You're also welcome to join us to the after SIMC party that is at DSO at 9 p.m. also tomorrow, and more information can be found on the Facebook event Carlos from SIMC 2025. And on behalf of the Student Scientific Society, I would like to thank you all for the participation in the session and would like to wish you a good afternoon.